I want you to imagine, just for a second, that you were driving your car down the highway.
Okay.
And suddenly, right there on the dashboard, the check engine light flashes on.
Oh, the worst feeling.
Right. It is bright red, it's glaring, and immediately your stomach just drops. Because that light means danger. It signals that something is, fundamentally wrong under the hood. So you do the responsible thing. You take the car to a mechanic.
Naturally.
The mechanic hooks it up to all their diagnostic machines. They run like every test in the book, and they come back with great news. The engine is pristine. There is absolutely nothing wrong with the car.
Which should be a huge relief.
It should be.
Right.
But then you get back in the driver's seat, you turn the key, and that red light is still on. It continues glaring at you.
And see, no matter how many times that mechanic promises the car is safe to drive, your brain simply cannot ignore that glaring light. Every single mile down the road, you are basically just bracing for the engine to explode.
It sounds totally exhausting. And today, we're unpacking what happens when that exact scenario plays out. But, not in a vehicle in the human body.
Exactly.
We are diving into a stack of clinical notes and practice overviews to really figure out how modern psychology has completely redefined what we all used to call hypochondria.
It's a fascinating shift in how we view it, really.
It really is. We're going to explore why that biological check engine light gets stuck in the on position and look at how access to specialized care is evolving to finally turn it off.
Yeah, and to do this, we have some really revealing clinical foundations on health and illness anxiety to work through, and we're pairing that alongside the operational details of a specialized telehealth practice based in Georgia.
Right, coping and healing counsels.
Exactly, or CHC. And this combination gives us a really great dual perspective. We get to analyze the theoretical diagnostic side of the problem while also, examining the practical boots-on-the-ground reality of how patients are actually getting treatment today.
So whether you are someone who constantly Googles every single minor ache until you are convinced of the absolute worst.
Which is very common, by the way.
Oh, incredibly common. Or maybe you're on the complete opposite end of the spectrum, right? You actively avoid going to the doctor out of sheer panic. Either way, this deep dive will reveal exactly why the brain gets stuck in that loop.
And crucially, what actually breaks it.
Right. But to really understand how to fix this, we first need to look at how the diagnostic definitions have completely shifted. And that starts with, throwing out a word I think we all basically grew up using. The term hypochondria is officially outdated.
Yeah, the clinical vocabulary has completely moved away from that catch-all umbrella term,
Right.
mainly because it lacked precision.
Too broad.
Way too broad. Today, what we used to call hypochondria is actually split into two related but very distinct conditions.
Okay.
So the first is illness anxiety disorder. This one is characterized by a severe preoccupation with having or acquiring a serious illness, despite the fact that the person has absolutely no physical symptoms.
No symptoms at all.
None. Or, at most, very, very minimal ones.
Okay, let me just put a pin in that to make sure I have the distinction clear. Illness anxiety disorder is like the person who feels totally fine physically, but they get a momentary, totally normal headache, and they're instantly consumed by the thought that a silent brain tumor is lurking.
That is a classic presentation, yes. The distress comes entirely from the perceived threat. It's not about a present physical sensation.
Right. The check engine light is on, but the engine is totally fine.
Exactly. Now, the second condition is somatic symptom disorder. And this operates a bit differently. In somatic symptom disorder, the person actually does have one or more real bothersome physical symptoms.
Oh, so they are actually sick or in pain.
Yes. The disorder lies in the fact that they are experiencing excessive thoughts, feelings, or behaviors in response to that actual physical symptom.
No, wait, let me push back on that second one a little bit.
Sure.
Because if someone genuinely has a bothersome physical symptom, say, I don't know, they have a verified herniated disc and chronic back pain.
Very painful, yeah.
Right. Why is their distress being diagnosed as a mental health condition? Labeling that as a psychological disorder feels like it flirts with being, dismissive. Like you're almost telling the patient the pain is just in their head.
And that is such a vital distinction to make, and it highlights a massive misconception surrounding these specific diagnoses. Somatic symptom disorder does not imply the physical symptom is fake.
Okay.
The physical pain from that herniated disc is entirely real. What elevates it to a psychological condition is the disproportionate reaction.
Disproportionate in what way?
Well, we're talking about a response so severe that the person might quit their job, alienate their family, and spend 12 hours a day researching experimental spinal surgeries for a pain level that would typically only require, say, moderate physical therapy.
Ah, I see.
And the diagnosis requires this intense health-related anxiety to persist for 6 months or more.
6 months, so it's not just a weekend of Googling.
Exactly, because acute worry over a new symptom is just a normal human reaction. We all do it. It's that unbroken 6-month period of excessive psychological distress and life disruption that requires mental health intervention. And that's independent of whatever's happening with the baseline physical symptom.
So the symptom is just the trigger, but the 6-month spiral of excessive reaction, that's the actual disorder.
You nailed it.
That makes a lot of sense when you frame it around the behavioral response. And looking at the clinical notes, this behavioral response typically fractures into two extreme camps, right?
It does, yeah.
On one end of the spectrum, you have excessive health checking. So this is the constant Googling of symptoms, repeatedly checking your pulse on your smartwatch, examining your skin in the mirror every single morning, and constantly scheduling redundant medical exams.
Yes, the hypervigilance.
Right. But then on the other end, you have complete avoidance. And this is a person who is so terrified of what a doctor might confirm that they skip their medical appointments entirely. Like they will not even walk into a clinic.
Right. It's two entirely opposite behavioral manifestations, but they're stemming from the exact same underlying mechanism of anxiety.
Which is wild to think about.
It is. The checking is an attempt to neutralize the fear through reassurance, like, tell me I'm okay, while the avoidance is an attempt to neutralize the fear by running away from the potential trigger. If I don't go to the doctor, I can't get bad news.
Out of sight, out of mind. Or at least attempting to keep it out of mind.
Right. And knowing what these two disorders look like, illness anxiety disorder and somatic symptom disorder, we have to examine what happens when these 6-month cycles of panic actually collide with the traditional medical system.
I imagine the impact on healthcare utilization is just massive.
It's staggering. The data indicates these conditions are incredibly common, affecting anywhere from 1% to 10% of the entire population.
Well, up to 10% of the population. That means millions of people are caught in this loop right now.
Millions. And for the group engaging in excessive health checking, they get trapped in this endless, wildly expensive cycle.
Because they're the ones constantly going to the doctor.
Exactly. They show up at emergency departments with chest pain that turns out to be a panic attack. They book multiple specialty consults. They demand advanced imaging, MRIs and CT scans. And they do all of this without any actual resolution of their anxiety.
The clinical notes highlight a really fascinating dynamic here, actually. When these patients go to the doctor, the physician's natural instinct is obviously to comfort them.
Right. Of course. That's what doctors are trained to do.
Right. The doctor runs the diagnostic tests, sees clear results, and tells the patient, you are fine. There is nothing wrong with you. But the literature explicitly states that this repeated reassurance from doctors is, quote, iatrogenically counterproductive.
That is a very heavy piece of medical terminology right there.
It really is. Let's unpack that. Essentially, iatrogenic refers to an illness or symptom that is inadvertently caused by the medical treatment itself. So providing reassurance is actively making the patient's condition worse.
Which sounds completely counterintuitive.
Totally backwards. But I view this almost exactly like scratching a mosquito bite.
Oh, that's a good way to look at it.
Right. You get bit, it itches, and you scratch it. And for that one split second, scratching provides this immense euphoric relief.
It feels great.
It does. But underneath the skin, you just inflamed the surrounding tissue. You basically guarantee that the itch is going to return 10 times more intensely just a few minutes later.
And what's happening neurobiologically backs up that analogy perfectly. The reassurance from the doctor acts exactly as the scratch.
Right.
It provides immediate temporary relief from the anxiety by lowering the central nervous system's threat level. But the relief is fleeting because the fundamental cognitive distortion remains completely unaddressed.
The underlying fear is still there.
Exactly. See, the entire medical system is built and trained to diagnose physical ailments. So when a patient cycles through specialist after specialist seeking answers for health anxiety, the very act of the doctor agreeing to run new tests reinforces the brain's false belief system.
Oh, wow. Because the brain interprets the action and thinks, well, if this highly trained specialist is ordering another MRI, there must be a legitimate physical danger they're worried about missing.
Precisely. The investigation validates the anxiety.
The check engine light stays on because the mechanic keeps opening the hood to look. which signals to the driver that there might actually be something to find.
That's exactly it.
So if traditional doctor reassurance is actively harmful, what is the actual evidence-based fix here? I mean, how do we break a cycle where the very act of seeking medical help makes the psychological problem worse?
Well, the clinical evidence points to a highly structured intervention. The first-line defense is cognitive behavioral therapy, or CBT, but it has to be specifically tailored for health anxiety.
Okay, but how does CBT actually tackle this on a mechanical level? It can't simply be a therapist sitting across from a patient just talking about why they're afraid of having a stroke.
No, it's not just talk therapy.
Right, there has to be a mechanism to actually stop the behavioral loop.
And there is. It's highly actionable. The CBT targets those reassurance-seeking behaviors through a process called exposure and response prevention.
Exposure and response prevention.
Basically, the therapist teaches the patient how to sit with the discomfort of the itch without scratching it.
That sounds incredibly difficult.
It is really hard work. In a session, a therapist might gently expose the person to a health-related trigger. So, for example, having the patient focus on a normal, minor bodily sensation, like a slightly elevated heart rate after walking up a flight of stairs.
Okay, and normally the patient would instantly check their pulse monitor or call a doctor.
Exactly. But in the therapy setting, they are guided to feel that sensation and actively resist the urge to seek immediate medical reassurance. And over time, by doing this repeatedly, the brain relearns that the physiological trigger is not actually dangerous.
And the anxiety response naturally diminishes.
Yes. The alarm bells stop ringing so loudly.
Now, the notes mentioned this behavioral rewiring is often augmented with medication, right? Specifically SSRIs, which are commonly used as antidepressants or anti-anxiety meds.
Yes, very frequently.
I imagine the chemical support from the SSRI kind of lowers the patient's baseline noise. Like it gives them the mental bandwidth to actually engage with the difficult exposure work of the CBT. Because if you're at a 10 out of 10 on the panic scale, you can't really do the therapy.
That is exactly right. That combination of behavioral therapy and pharmacological support is highly effective. However, and this is a big however, there is a third pillar to this treatment that is absolutely vital.
Okay, what's the third pillar?
It relies on coordinated communication between the patient's primary care provider, their PCP, and their therapist. They have to coordinate around a concept known as limit setting on medical testing.
See, I have to ask about the logistics of that.
Yeah.
Because how does a therapist step in and coordinate with a primary care doctor to tell them to stop running tests on a mutual patient?
It's tricky.
From the outside, that sounds like it could turn into a massive turf war between clinical psychology and physical medicine.
It definitely requires a delicate, collaborative shift in the care paradigm. But think about the physician's dilemma here.
Okay.
A patient is sitting in their exam room, genuinely terrified they have a terminal illness. If the PCP simply refuses to run tests, the patient feels abandoned.
And they'll probably just go to a different doctor or the ER.
Exactly. Plus, the doctor carries the liability and the personal fear of missing a genuine physical illness. But when the therapist and the PCP communicate directly, the PCP gains the clinical context. They know the patient is receiving active, ongoing psychological support for their health anxiety.
So they aren't just leaving the patient high and dry.
Right, and this allows the doctor to confidently step back and implement boundaries on unnecessary imaging or specialist referrals.
So what does that conversation actually sound like between the doctor and the patient?
Yeah.
Because it has to be incredibly tricky to deliver that news without triggering the patient's fear of abandonment.
A skilled PCP will frame it collaboratively. They might say something like, "We have thoroughly ruled out acute physical danger. I am in contact with your therapist, and we agree that running another MRI will actually harm your recovery by feeding your anxiety."
That's a very clear boundary.
Very clear.
Yeah.
But they follow it up with, "I am not abandoning your care. I am here for you, but we are treating the anxiety now, not the physical symptom."
Wow. That is a profound shift. The doctor gets the clinical coverage to stop the iatrogenic harm because they know the therapist is essentially catching the patient.
Yes, it creates a unified front.
A unified front that prevents the anxiety from just exploiting the medical system, which honestly brings up a massive operational hurdle.
Access to care.
Exactly. Knowing that highly structured CBT combined with coordinated care and limit setting is the solution. How do patients actually access this?
That is the million-dollar question.
Right. It's one thing to have clinical literature saying, oh, just do CBT. And it is an entirely different reality to actually find a specialized therapist, coordinate with a PCP, and frankly, afford the care,
Sure.
especially given the geographical and financial barriers that are just plaguing modern healthcare.
It's incredibly difficult, and this is exactly where the operational models are forced to innovate. So, coping and healing counseling, or CHC, that practice we mentioned earlier, they serve as a prime case study for modern delivery of this exact type of care.
Yeah, looking at CHC's operational model from the practice overview, the first thing that really jumps out is their delivery method. They operate as a 100% telehealth practice.
100%.
They are fully HIPAA compliant and licensed to serve all 159 counties across the state of Georgia.
Which is huge. Operating statewide like that requires substantial infrastructure. They utilize a really diverse, culturally competent team of over 15 licensed therapists. And this includes licensed clinical social workers, licensed professional counselors, and licensed marriage and family therapists.
Having that specific mix of credentials like marriage and family therapist makes total sense when you realize health anxiety does not happen in a vacuum.
Yeah, absolutely not. It impacts everyone around the patient.
Right, a severe 6-month spiral of illness anxiety disorder is going to heavily strain marriages and completely disrupt family dynamics.
Yeah, the ripple effects are huge.
So it's good that CHC services span individual therapy, couples counseling, family therapy, and even teen therapy for ages 13 and up, plus life coaching. And they also specialize in treating depression, trauma, grief, and general stress right alongside the anxiety.
They cover a lot of ground, but what is truly disruptive about their model, in my opinion, is the financial accessibility.
Because cost and location are the primary gatekeepers to specialized mental health treatment.
Always. Many patients who desperately need exposure therapy simply cannot afford weekly out-of-network rates. It's just not feasible.
And CHC attacks that barrier directly. I was amazed looking at this. They accept Medicaid, and for Medicaid patients, the copay is $0.
That is extremely rare for specialized care.
A $0 copay. And for commercial insurance, they take Aetna, Cigna, Blue Cross Blue Shield, United Healthcare, and Humana. And depending on the specific plan, those sessions range from $0 to $40.
It's remarkably accessible.
A $0 Medicaid copay combined with a statewide reach means telehealth becomes this massive system equalizer. It does not matter if a patient lives in downtown Atlanta with a dozen clinics on their street, or if they live in a deeply rural Georgia county where the nearest anxiety specialist is literally a 3-hour drive away.
Right.
This specialized care can be delivered directly into their living room.
And if we pull this back to the clinical definitions we explored earlier, the telehealth model itself functions as a clinical accommodation.
How do you mean?
Well, consider the avoidance behavior we discussed earlier, the patients who are so terrified of doctors that they refuse to go to medical appointments entirely.
Oh, the people who will not even walk into a waiting room because the smell of the clinic or the sight of a white coat triggers a full-blown panic attack.
Precisely. For a patient whose health anxiety manifests as severe avoidance, forcing them to drive to a clinical building to sit in a clinical waiting room just to talk about their health anxiety, it's often an insurmountable barrier.
They just won't do it.
They won't. But a secure, 100% telehealth option might be the only way they're willing to initiate care. They can start the incredibly uncomfortable process of exposure and response prevention from the safety of their own couch.
It bypasses their primary environmental trigger entirely.
Exactly. The delivery format itself lowers the barrier to entry.
That is brilliant. For anyone in Georgia who might be recognizing themselves, or maybe a family member, in this cycle of excessive checking or avoidance, having access to these resources is absolutely critical.
It's the first step to getting your life back.
CHC's contact details, as listed in the practice overview, are their website at cheaththerapy.com, their email at support@cheaththerapy.com, and their main phone line at 404-832-0102. Having an accessible off-ramp like that is really the first step out of the loop.
It represents a comprehensive model that synthesizes the clinical necessity of specialized CBT with the logistical reality of how patients actually navigate the healthcare system today.
It really does. So to briefly recap the journey of this deep dive today, we started by redefining the landscape, moving away from that outdated term hypochondria to understand the precise mechanics of illness anxiety disorder and somatic symptom disorder.
Right, splitting it into the two distinct paths.
Then we explored the really frustrating trap of medical reassurance, uncovering how the very act of checking actually inflames the underlying anxiety over that 6-month cycle. We broke down how specialized CBT, exposure therapy, and coordinated limit setting with primary care doctors can effectively dismantle that cycle.
The three pillars.
Exactly. And finally, we analyzed how accessible statewide telehealth models, like CHC in Georgia, are systematically removing the geographical and financial barriers to deliver that care.
The progress in treatment is substantial, there's no doubt about it. But, the mechanics of these disorders actually raise a highly provocative question when we look at our current environment.
What are you thinking?
Well, we discussed excessive health checking behaviors earlier, right? Things like repeatedly taking a pulse or Googling symptoms.
Yeah, the hypervigilance.
But today, millions of people wear smartwatches, devices that constantly monitor heart rates, blood oxygen levels, and sleep cycles in real time.
Oh, wow. Yeah.
And they deliver push notifications about minor physiological changes right to your wrist. As biometric tracking becomes deeply integrated into daily life, how much harder will it become to resist the urge to health check?
That's
I mean, could the everyday wearable technology designed to keep us healthy be inadvertently fueling the exact hypervigilance that triggers illness anxiety disorder?
That is a fascinating and honestly heavy thought to leave on. Are we basically strapping the biological check engine light directly to our wrists, where we can never ever look away from it?
It's definitely something to consider.
Something to seriously mull over the next time you open the health app on your phone to review your daily data. Thank you so much for joining us on this deep dive. Keep questioning the systems around you, keep learning about how your own mind works, and above all, stay curious.